Jeanie, one of the things we should talk about are the specific and unique challenges faced by emergency physicians in taking care of people that are at the extremes of age. Both the elderly and the young have unique challenges in mitigating risk in the ED. Let's start off by talking about the younger generation and the unique problems that are associated with taking care of pediatric patients in the emergency department.
You're right, Graham. Pediatric patients are a very high-risk patient population and a real challenge for emergency department physicians. The most common types of claims in emergency medicine involving pediatric patients include meningitis, missed appendicitis, fractures, and testicular torsion. Appendicitis and meningitis are the most commonly missed diagnoses in pediatric patients in the emergency department, and the pediatric claims are often more apt to be settled rather than risk turning the decision over to a jury who may be overly sympathetic when a child is involved.
Jeanie, let's talk about some of the specific high-risk clinical cases that we see in pediatric emergency medicine. I think meningitis, obviously, you and I both talked about this, in terms of severity, it really comes up there. That, you know, if you make a misdiagnosis of meningitis, it not only has consequences, obviously, for the patient, but also in terms of the patient safety and med-mal arena. So how do you not miss meningitis? Well, it can be a very difficult diagnosis to make early on. Frequently, these children will present with low-grade temperatures or viral syndrome. So in order to pick those patients up that might slip through the cracks, we've talked about the value of doing serial exams and keeping children around. We also need to have a discussion about these patients need to be placed in a gown, because if you're going to look for petechia or rashes, another sign or symptom of meningitis, then you want to make sure that they're in gowns. We need to make sure that we have accurate temperatures, so rectal temperatures, to diagnose fever in the little ones. And then also the power of observation, which is so important in deciding whether a child's sick or not. And by that I mean really observing the child from afar before you actually even enter the room. Are they interactive with the patient's parents? Are they playful? Will they grab an object? Are they feeding well? Those are some of the signs or some of the tips to help identify meningitis early on. Let's switch gears and talk a little bit about appendicitis. The most common misdiagnosis for appendicitis is gastroenteritis, and I think it's really important when you're writing that diagnosis down, particularly in a pediatric patient who may not have diarrhea, that you stop and you think, could this be an early appy? And the problem with appendicitis, it too can be very subtle early on. We don't usually miss the patient that's, you know, got a bored, rigid-like abdomen and is pointing in their right lower quadrant and has a fever of 104. So it's the subtle presentations and realizing that the presentations can be subtle. Back to what I said earlier, particularly for appendicitis, the value of time can't be overstated. It's really important to do serial exams, and they're very valuable in ferreting out this diagnosis. The other two things that I would say that are most important about are CT scans. When I trained, we made the diagnosis by history and exam, and now a lot of people have become dependent upon CT scans. And there's a lot written now about the potential dangers of doing CT scans on children. So I think people are pausing now, thinking about that. It's an important communication point with the parent. I think it's also important to realize that there can be both false positives and false negatives. So just because you have a negative CT scan doesn't mean you don't have appendicitis, and engaging the parents in that discussion. Last but not least is certainly this is not a diagnosis to send somebody off on a Never Never Land for follow-up. They need to be seen within 8 to 12 hours by a provider to recheck. So I think those are some of the ways that we can head off some of the risk by missing this diagnosis. Let's talk about fractures, because fractures and wounds have always been in the top 5 in terms of frequency of litigation and malpractice in the emergency department. I think the most important caveat is really to treat those types of injuries as if there were a fracture. So ice, elevation, splinting, making a decision about whether they need crutches or not, engaging the parents in a conversation that says, I don't see particular fracture on the imaging study, but there are two things you should know. One is that sometimes it's difficult to see a fracture, particularly some of the Salter type fractures, on an x-ray. And the second is another set of eyes, a radiologist is going to look at these films, and if they see something they're worried about, we will call you. So you embrace the uncertainty of a definitive diagnosis with the parents, and you tell them that up front. The last one is really testicular torsion, and I think the most common misdiagnosis from a risk perspective for torsion is epididymitis. And so when you write that diagnosis down in a young male, you should pause and just think, could this be torsion? And if torsion is in the differential diagnosis, then you should get an imaging study and a consultation without delay. Absolutely need to engage a urologist if you think this is testicular torsion. You may want to get the imaging study, and that may require some logistics. The point is, don't wait. You can do both simultaneously. Get the imaging study, talk to the urologist, do it simultaneously. One of the reasons that we miss this diagnosis is we don't think about it. And a couple of other caveats about testicular torsion. One is, this is an entity or a disease state that can also detorse. So the patient may be in acute pain at home and have a good history, but by the time you see them and examine, they've detorsed. I've seen that several times. And one of the most important things in considering this diagnosis for any young male with abdominal pain or referred pain like flank pain is to do a good, careful GU exam. And many times we're more worried about appendicitis or something else that we don't think about abdominal pain being referred and the possibility that could be torsion. I've seen that many times. Are there any unique challenges which we should have a discussion about in this particular patient population?
Certainly. Some of the special challenges that emergency department physicians have to deal with when they're treating pediatric patients include that the presentations tend to be more complex, so it's more difficult for the emergency physician to sort that all out and decide what all of the differential diagnoses are. And additionally, the presentations tend to be more atypical in pediatric patients than they do in the adult population. Also, histories are told by third parties versus being told directly to the physician by the patient, as you would experience in an adult population. ED physicians are also challenged by having to treat two patients when they're treating a pediatric patient, and if both parents are present, then you're actually treating three. Parents are understandably anxious when their children are ill, especially if it's an infant or a toddler. And the parents may arrive with expectations for care. For example, they may bring a child in with a very minor head injury, fully expecting that the physician is going to order a CT, and it takes a lot of communication then for the physician to convince them that a CT isn't necessary. On the other side of that, parents may come in with a child with a more significant head injury. The physician feels a CT is indicated, but the parents have heard or read about the risk of later malignancy, so they don't want you to order a CT. So you can see how complicated it gets. And the challenge for the emergency physician, as you know, is to make both groups feel as if they've received the best care possible.
Well said.